PR positive patients, there was a longer survival, HER2 negative, of course, and younger women were doing well, and bone-only metastasis. So it did show at the 5-year point that there was improved survival in patients receiving surgery. But again, patient selection becomes very important. And this is the TMH study where patients who were metastatic breast cancer at first presentation were planned on anthracycline-based treatment, followed by loco-regional treatment and no loco-regional treatment. And it clearly showed that there was no overall survival benefit compared with those who did not receive any loco-regional. You still can't see?
We can see.
Okay, with no loco-regional treatment. There are some people who cannot see it. Slides not visible, it seems. So, so it did not increase the local progression-free survival, but did decrease the distant, just a second, but did so again, you can see that there is no difference between the median overall survival, whether it was loco-regional treatment or a no loco-regional treatment, even at 2 years at 2 years of assessment. And most of these patients did not receive HER2-directed therapy, but that was happening in both the arms. So now let me take you through this particular study, which was the BOMET MF 1401. This was again presented in the San Antonio Symposium in 2021. So this was a prospective registry study of patients with stage 4, and they took only bone-only metastasis at presentation and compared patients who were receiving loco-regional treatment versus systemic treatment only. And the primary endpoints were again progression-free survival and overall survival. So this was the randomization. So it could be just systemic treatment, or it could be local therapy followed by the local therapy could be following the systemic treatment, or the systemic treatment could follow loco-regional therapy. So in this, again, the surgery group, it was younger than the systemic therapy group, and most of the patients were T3 tumors. There were quite a few T3 tumors. And so the oligometastatic, the solitary bone was about 32%. Oligometastasis was 22%. So all in all, we're looking at this group, which was about 54% of the study arm. So what they saw was the group with the loco-regional treatment, the median follow-up was 33 months, and the systemic was 34.9%. And this was the surgery that was performed. It was mastectomy in 69% and breast conservation in 31% of patients. So now if we look at the local recurrence-free survival, in the local treatment arm, it was 78%, and it was 52% in the systemic treatment arm with the hazard ratio of 4.51. And systemic progression-free survival was also better in the loco-regional treatment group as compared to the systemic treatment group. So on the whole, the 5-year overall survival was 72% in the loco-regional treatment group compared to 33% in the systemic treatment group, with a hazard ratio of 0.4%, 0.4, which is extremely good. But of course, this is a very, very select group of patients. So surgical intervention did contribute to improved overall survival in the hormone receptor positive patients and also in the HER2 positive. So in triple negative, they were not able to demonstrate a survival benefit. So this local regional treatment was independently associated with survival, and multiple metastases also were doing fairly well. So benefit of surgery was shown in patients with bone-only disease. So we must be very, very careful what we're discussing. This is a bone-only disease. So of course, if you have a higher burden of metastatic disease, the outcomes are poor, and patient selection is the key in this case. So this is an old paper, which is 2011, but it still holds true that local regional treatment of primary disease is associated with improved survival in some women. So we cannot write off all patients with limited metastatic disease, and we must choose our patients carefully and restrict it to those patients with who are young, who have a good performance status, who are ER/PR positive disease with clear margins, and distance disease limited to uh, one subsite, but of course now they say three subsites, but fewer than 5 metastatic lesions. So that is my message to you. Super selected patients can benefit with surgery in oligometastatic disease. I rest my case. Thank you. And really sorry for the technical glitch.
That's a very fantastic, no, but it was it went well. Just one or two small glitch. Very good. So over to you, Vani, now. And then after that, I request both of you jointly analyze each other's slides and say pro and con for the benefit of the student. Then take the Q&A.
One, you may unmute and start a video.
Yeah, I'm doing that. It's just that just trying to go through that screen one step, but it is not opening here. Yeah, okay. Screen. Just give me a second, okay? I don't want to. Uh, all right. Is my screen visible now?
Yes.
And is it moving?
Click once on the. Yes, it's moving.
All right. So let me go back to this again. So we've just heard Geeta talking about the role of surgery, and I'm going to be focusing on the topic that was given to me, that is oligometastasis. We are debating on whether surgery should be done in a patient with oligometastasis or not. We are so when I say oligometastasis, we have to be very clear that metastatic breast cancer are classified into two: limited metastasis versus polymetastasis. And oligometastasis is where we have a limited metastasis. This is a separate subgroup, obviously because of the disease behavior and the way it progresses. So, understanding what is the recurrent breast cancer, first of all, when early breast cancer presents and we have finished the primary treatment, about 20 to 30% would eventually recur at some point of time. Obviously, when time goes to, and this is dependent a lot on the biology of the disease, the treatment taken, and the obviously the duration of follow-up. And I'm not getting into the pattern of recurrence, etc. 5% of all presentations anywhere, whether be it in what we have seen in India or we look at Western population, will present as de novo metastatic breast cancer. Of this 5%, a fifth, that is 20% of them are actually oligometastatic disease. And why is the incidence of oligometastatic seen the way it is? It's because of the use of minimally invasive loco-regional treatment being much more, increased sensitivity of advanced imaging, intensive follow-up protocols that are still being followed in spite of no evidence of benefit, and obviously increased awareness. So there is alertness about looking out for something. And the more sensitive a test you use, the more you're going to pick up disease which is asymptomatic and early. So oligometastatic disease basically is considered to be an intermediate state between the limited or controlled, say, early breast cancer and a diffusely polymetastatic disease. And the reason here is obviously because of restricted virulence. And thus, there is a delay in the outgrowth of these metastatic sites. But to make it easier to understand oligometastasis and to drive my point home on no surgery for oligometastatic disease, I would classify oligometastatic into three subcategories. One is a genuine oligometastatic breast cancer, which is treatment naive, de novo, with no previous history of polymetastatic disease. Now, what Dr. Geeta just explained metastasis. These are the genuine oligometastatic breast cancers where there is some evidence now that treatment given, and some of these are actually part of even randomized trials, the treatment given in the form of local regional therapy does cause improvement in when we talk about. And the other two categories, these are the oligo-recurrent breast cancers, which are metachronous oligo-recurrent breast cancers. Post primary treatment, there is a low burden of metastasis, so maybe synchronous or metachronous. Now synchronous, I will take it into the same genuine oligometastatic, but metachronous is after 6 months when they come back with a solitary bone, solitary liver, solitary brain. These are the ones with low burden metastasis. And the last of all is the induced oligometastatic breast cancer, where patients have polymetastatic disease, systemic therapy is offered, and now they have very limited disease. There's a temptation to offer surgery to them because now they have responded well. So, do these responders with oligometastatic disease fall into the same category as the genuine oligometastatic? We will see. So, this is the same pictorial depiction of synchronous, oligorecurrent, and the intermediate state. But I will start with one statement that not all oligometastatic breast cancers are similar. And why do I say this? So if you look at the oligometastatic disease, there is a heterogeneity in the way oligometastatic disease presents. Now, the definition itself has varied from place to place and time to time. So there is an arbitrary cutoff based on different types of histology and not specific to breast cancer alone. So when you look at the retrospective data, there is a lot of data on benefit of doing surgery in oligometastatic disease in non-breast cancer diseases, especially colorectal and others. So here there is a benefit of offering surgery even to the metastasis. But in breast cancer, there is, as Geeta has already shown, there is limited evidence. Now, will 1 to 3 oligometastasis behave better than 4 to 5? I think it's a very logical thinking, and it's very obvious that the lower the number of metastases, the better the outcome for the patient. At the same time, it's very dependent on the response to and the kind of systemic treatment that is being offered. For example, if you have a HER2 positive de novo metastatic breast cancer that is treated with trastuzumab with a complete response, they will behave as even early breast cancers. So you really have to know that whether this cancer, the biology of it is bad or the biology is good enough for it to have a treatment. Then again, there are unclear definitions of saying less than 5 metastatic sites, less than 2 organs involved, less than 5 centimeter lesion, and each one of these will behave differently, and hence there is a heterogeneity in the way oligometastasis will behave. And there is a prognostic association with the correct definition. The minute you have defined your oligometastatic group, you'll find that outcomes will change. So even within the trials, if you see the metastatic breast cancer trials, there have been involvement or inclusion of oligometastatic disease. And I will refer to a couple of them now. But the most important thing one must remember is oligometastasis is defined by prognosis but evaluated by cure. That means your intent in a treatment when you're doing oligometastasis, patient with an oligometastatic disease, your intent is to cure the patient. That means you're treating them as if they are early breast cancers or they're locally advanced. So this is totally defined by prognosis. And treatment is not intention, the intention is not to reduce the volume of burden, not to prolong survival or alleviate symptoms. It's PFS, which is the endpoint for an oligometastatic disease. That means you have to significantly improve the progression-free survival. Now, understanding prognostication. As I've already said, number of sites involvement less, there is better prognosis. Site involved again decides outcome. Brain met versus bone met, there's going to be a difference in the way the patient behaves, even if it is solitary. So all of these will impact on the outcome of oligometastatic disease. But there is better prognosis, as has already been stressed by Dr. Geeta, with younger age, favorable performance status, longer disease-free interval post-primary in the second group of post-primary treatment disease or oligo-recurrent disease, non-triple negative breast cancers, if there is no involvement of central nervous system or liver, and biology related. So a no bone, no central nervous system involvement in a HER2 positive will do better than a HER2 positive with a brain met. So all of these have to be kept in mind when you're deciding the treatment for a patient with oligometastatic site. We have already seen the benefit of surgery is absent in a M1 status in breast cancer. Though there is enough evidence in retrospective data to say there is benefit of offering local regional treatment in improving PFS and some benefit in improving OS in the retrospective evidence. And this is completely related to a selection bias. The minute we look at the prospective randomized trial, the benefit of surgery is shown to be absent. The same 4 trials that Dr. Geeta referred to, there is no difference in overall survival when you offer local regional therapy. The MF07 Turkish trial is the only one which came up with a better 5-year overall survival in a bone-only oligometastatic breast cancer. Now, this study was not designed to answer questions for oligometastatic breast cancer. So I think this is a completely a subgroup analysis because their predominant inclusion happened to be oligometastatic, and the difference in this trial compared to the TMH trial was that they took upfront decision for doing surgery versus not. So they had to have patients who were already selected from upfront. That means where surgery could be offered. Whereas TMH trial looked at everybody getting a systemic therapy, and all the responders where the debate comes in of polymetastatic becoming oligometastatic. But I'm not saying that we had oligometastatic breast cancer as the question. They were randomized after responding to surgery versus not. In them, there was a stratification for less than 3 metastases versus more than. Now, less than 3, some of them would be called now by definition as oligomets, but remember they were polymetastatic to begin with and then they became that. So the randomization was after response. So the number of sites included really was less than 3 versus more. But the true oligometastatic, solitary metastases were never included, were excluded from the study. Obviously, in any study, sometimes there is deviations. We had 11 patients in this study who were true oligometastatic who were included, but the 11 out of the 350 will not impact outcomes. So what have we learned from the M1 trials? We have learned that there was no benefit in overall survival in spite of good local control. Treatment for the distant site was not a part of the design. So some of them received distant treatment, some did not. So that today's time we would say may not impact. Benefit in isolated bone-only metastasis is very clear in all the studies that we have seen, whether they were randomized trials or they were retrospective evidence. And 2 of the 4 randomized trials did not report proportion of the oligometastatic breast cancer as per current definitions. So 25% in the Tata study, TMH study, had less than 3 metastatic lesions. That was a stratification and excluded true isolated oligometastatic breast cancer. But 30% of the MF07 Turkish trial had isolated lesions or true oligometastatic breast cancer, and data was missing from the remaining 2 studies. So our topic for debate today is, should we do a surgery in oligometastatic breast cancer? So looking at the current level of evidence, are we able to answer this? What is the data available for oligometastatic breast cancer? Retrospective evidence, multiple of them, excellent prognosis in oligometastatic breast cancer, undergoing multimodal treatments, including local regional strategies. And as I've said, most evidence from oligometastatic cancers is all cancers, but oligometastatic breast cancer itself, there is evidence to say there is outcome benefit if you look at the de novo. The prospective pooled analysis of 3 trials of anthra-based chemotherapy in patients with stage 4 breast cancer, well controlled after radical surgery for isolated recurrence, again showed there was some benefit. So this is the second group that I spoke about, that is post-primary treatment when there is an isolated recurrence depending upon various factors. But this is that subgroup which is really impacted by various confounders. And of course, benefit in bone-only disease, which is not debated. So what is the take home? All were clinically driven, non-randomized study data with a predominant selection bias to decide to offer loco-regional therapy. Now, can we, based on this data, start offering surgery to all oligometastatic breast cancer? You look at Netherlands Cancer Institute data, 10 years data on 239 patients. Now, remember that the oligometastatic breast cancer is a very small subpopulation. To be able to run a prospective randomized trial in these, will probably require 10 years, 15 years before you even generate enough information because the incidence itself is very low. 53% of these data patients were metachronous, 47% was synchronous oligometastatic breast cancer. And I'm assuming all of you understand what is metachronous and synchronous. Again, bone only was nearly half of them. Node only was 23%. So you can see that 78% of the patients had actually limited, very limited disease, non-visceral, and ER positive in 85%. So this is the kind of disease which would present with oligometastatic spread. Now, if you look at this is now just a cohort, which was the outcome was put up. So overall survival 93 months, and the event-free survival 41 months. Obviously, a very good outcome. why would you not offer surgery for an oligometastatic breast cancer, which is falling into the first two categories? Now, oligometastatic breast cancer, again, if you see what impacts them, those who have systemic therapy, if there is a complete response, as you can see here, they would do better. But those who were triple negative or had poor response to systemic therapy did badly. That means they had progressive disease. Similarly, when you look at the adjusted hazard ratios, again, they are for recurrence or progression. Now, this is for death and this is for progression. The triple negatives and the progressive disease did badly. So, triple negative short DFI less than 24 months and progressive disease on systemic therapy indicated poorer outcomes for both overall survival and event-free survival in oligometastatic breast cancer. Now, these I'm talking about are not the de novo ones. These are the ones who have received some kind of treatment. So I'm just bringing in the data that we had, older data of Tata Memorial, where we had seen, looked at 3,000 patients between 2003 to 2010, 7 years. And we had only 105 patients with genuine oligometastatic breast cancer de novo. These were compared with the metastatic breast cancer de novo subset and locally advanced with no metastasis. A total median follow-up of about nearly 3 years. Bone metastasis was the most common in oligometastasis, 70% of them. And polymetastatic disease, MBC patients that were compared, they had more of visceral metastasis in 40%, and bone only was 28%. So you can see these are two different kinds of cohort, they will behave differently. And obviously, when you look at the outcomes, the no oligometastatic patients, these are the ones which are too locally advanced when we do a MET workup, compared to those with locally advanced or large operable breast cancer with oligometastasis, it's the graph curves are much closer as compared to a true metastatic polymetastatic patient who are mapped here. Now, this is for disease-free survival, and overall survival also seems to be closer to those with locally advanced. So, obviously, there are a subgroup of patients with metastasis, limited metastasis, who do much better than polymetastatic disease. Now, this is all about the primary. So, we have to be super selective in the primary. You can't be offering surgery to all, and you have to look at the DFI, the biology, disease site, and then take a decision regarding addressing the primary site or not. Now, when we move to the next, what do you do with the distant site? There is one trial, the NRG VR002, which was presented as a poster in an oral abstract, poster and an oral abstract, where there was a phase 2, phase 3 trial of standard care systemic therapy with or without stereotactic body radiotherapy or surgical resection for newly oligometastatic breast cancer. What does it mean? They took the de novo metastatic breast cancers or early, the synchronous oligorecurrent, where they looked at systemic therapy with or without treatment to the distant site. Here, the local disease or the primary disease was already controlled. That means they had already offered surgery to or treatment to the primary. So the goal of treating this was cure, measured by progression-free survival, not prolongation of overall survival. Again, it investigated the role of metastasis-directed therapy receiving first-line systemic therapy. And it included patients up to about 4 metastatic lesions, all amenable to surgery or radiation, with controlled locoregional disease, and 12 months of first-line systemic therapy with no progression. So there was already a time gap that had happened. Now, this is a second subset that we're talking about. Post-primary treatment recurrence, now receiving first-line treatment for oligometastatic breast cancer, and already a time duration had already passed. 20% only were synchronous with the primary disease. So 80% of them were metachronous. This is a different subset, and here we are looking at addressing the recurrent disease versus not. 125 oligometastatic breast cancer, 79% of them were hormone receptor positive, 13% HER2 positive, 8% TNBC. You can see from the biology itself, what is the kind of disease you expect in such patients. This trial failed to meet the primary endpoint of progression-free survival. That means, and if you look at the actual numbers, 19.5 months versus 23 months. 19.5 for those who received treatment versus 23 who did not. That means there was a detriment which was seen not statistically significant, and there was no overall survival benefit. So again, this does not support ablative treatment for distant metastatic site in oligometastatic breast cancer. And it is related. If you look at overall subset of oligometastatic breast cancer, they have a favorable term outcome with nearly 70% overall survival at 3 years. And the median PFS is best improved with more effective systemic treatment first, that to biology driven standard first line approach. So, where do we stand today then? There are multiple prospective randomized controlled trials, phase 2, phase 3 are ongoing for local ablative therapy plus systemic therapy. This is where we are going to get the answer for doing a local treatment versus local treatment plus systemic treatment versus systemic alone. Now, these are all going to be completing somewhere from one of them is expected to get over this year. I still need to know what the accrual is because I'm expecting the accruals to be slower than projected. But everything will take at least another 3 years or even more for us to get the answer. And most of them have a primary endpoint of progression-free survival. They have looked at local treatment with surgery or radiation as one of the local regional therapy options. And the number of sites have been limited into less than 3. Some of them have gone up to a single lesion less than 5 centimeter. So as you can see, the definition is again little broad, but they are limiting themselves to oligometastatic disease and not to polymetastatic because that question is already answered with 4 randomized trials. And any tumor biology or limited to HR positive is what the inclusion criteria is. We have to wait for these studies to finally take a call on what is the line of treatment that we should be offered for patients with oligometastatic disease. So if you ask me as of today, what are we going to take home today from this? Genuine or oligometastatic breast cancer, treatment naive, de novo with no previous history of polymetastatic disease, we are offering surgery to them and treating the distant site as well, even though there is one phase 2 study which said there is no benefit. But if you look at the other two groups, the metachronous oligorecurrent breast cancer post-primary curative treatment with low burden metastasis, we are still in a gray area. There is some evidence of benefit if it is synchronous and is taken up together. But I would say that a metachronous, which is obvious because it is of a short disease-free interval, is a triple negative breast cancer, poor outcome disease, not much of systemic therapy available. In such situations, I think we have to do individual value judgment and whether offering treatment to the primary or to the distant site is ever going to help. And this is primarily for the distant site, oligorecurrent. But sometimes you are tempted, say if you have a local recurrence, a single nodule in the breast, and you have solitary bone met, you would tend to go ahead and do this as a a mastectomy or a wider excision of the breast and go ahead with doing a distant site treatment. Majority there would be a mastectomy with a distant site treatment, but these are oligorecurrent. There is zero evidence in this. Unless and until you have enough evidence to say this will benefit, I think it's going to be based on biology of the disease, available systemic treatments, how the patient has responded, what's the disease-free interval. Without this information, you cannot take a decision to do a surgery just because the number of sites are low. And the last of all is the induced oligometastatic breast cancer. I think the case is closed here because these are patients who are polymetastatic to begin with, and then they have become oligo after treatment. There is no role of doing an surgery in these patients, and that is clearly shown from the TMH trial because these are the induced oligometastatic, the 25% less than 3 metastatic sites after systemic therapy. So I think these are the patients where you would not benefit at all, and this is a no-no completely for offering surgery. So in conclusion, all oligometastatic breast cancers are not the same. They may be post-primary treatment, poor biology, short DFI, limited options available. So they are not going to behave the similar way. De novos definitely behave better, and one can offer them surgery for primary and distant, but has to be individual case basis. And addressing a distant site by surgery is still debatable, no benefit seen in the randomized trial. And achieving an R0 status appears questionable in oligometastatic breast cancer. And this needs to be kept in mind and patient counseled for it when decision is taken to offer surgery for oligometastatic breast cancer. So that's all for today. I'm open to any questions. I will stop sharing my slide now, and I think we will take the questions as they come.
Thank you very much, Vani. That's fantastic. Before you take the questions, can both of you, in nutshell, for 2 minutes now, comment, like balancedly on each other's presentation so that students can get a take-home message?
So thank you, Dr. Vani. You have actually endorsed what I've said. So, you have to take a very clear message. I think, sometimes in patients like these, like I like the term that you use, which is genuine oligometastatic disease. Uh, when there is a solitary lung or a solitary bone, or even if there are 2 or 3 bone metastases, I cannot say, the randomization is not going to happen, because how is it that you can, deny treatment to somebody who is potentially a case for, surgical treatment? The randomization is going to be tough. I'm sure all these studies that you showed, most of which are radiation-based trials, it'll be tough to accrue patients to it. But having said that, one thing that needs to go out very, very clearly is you have to be very, very super selective. I think sometimes the selection bias here works for the patient's benefit. It has to be a young patient, it has to be preferably hormone sensitive. Even HER2 positives, I tend to be, there is emerging data that HER2 positives who are subjected to targeted treatment, again, do extremely well on systemic treatment. And these are patients, like Dr. Vani said, who present with minimal metastasis at presentation. Somebody has already been treated for polymetastatic disease as residual. I don't think that's a great case for doing surgery, because they are bound to fail. And then when you're in your clinic, what becomes important is the conversation that you're having with your patient. You have to tell her, look, you could fail 3 months down the line, you could fail 2 years down the line, I do not know, because that is the kind of evidence we have in this space. But you are a favorable subset, and we have seen, it's purely anecdotal then. We have seen patients do well, and we hope that you would also do well. But things can go wrong, because technically the disease has moved out of the realm of the breast and the lymph nodes. So she is metastatic by definition, but limited disease give her the hope of cure, because we have seen patients who have done extremely well, especially the ER positive metastasis. We will keep looking for evidence, but I'm not sure we will find that kind of robust evidence, because you can see the numbers in all those trials. They're all in their 200s. That's the maximum that they are hoping to accrue. And whether we will get any sensible answer out of it is tough to say. Eventually, what is going to happen is, when all these trials happen, there's going to be a meta-analysis, and then possibly we'll have some answer coming out of it.
Right. So, Geeta, you kind of summed up everything for me. But we do know that there is the subset which is genuine. And I think in those, I would still offer them a surgery, both for primary and, if possible, for the distant side. And that kind of stays with our definition of oligometastatic breast cancer, where we are offering treatment too. That means treat the primary and treat the distant. I don't think that one phase 2 trial that has come up as a RCT which showed no benefit, where primary was already treated, and these are oligo recurrent. There's a different subset only. So I don't think we are going to take home anything from there to apply it to a upfront oligometastatic breast cancer. I would still treat. As far as those presenting within a, with a long DFI, a solitary side, they've shown to be good behavior, young patients, and with systemic therapy available, whether HER2 or not, I'm still going to offer them some kind of a treatment for them. But not one of those who come with a, evident poor biology disease. Those are not the ones to be addressed at all, and especially so if post systemic, if they've responded well, I would say they are the high Ki67 aggressive disease that have responded well to chemo, and I would not offer them treatment for that particular disease. So that is how I would take it, and I think we have most of the things that are very clear in both the presentations. So I guess we'll just take the question and answer now. There's nothing more to be said beyond this. So there is somebody here who's asked about biopsy or FNAC from metastatic tumor. Is it necessary to label a breast cancer as metastatic? What should we consider the patient as if the PET and distant lesion is non-targetable? The lesion is about 0.6 centimeter on the scapula, but lesion is not visible on CT, only visible in PET. Right. So there are two questions here. One is that, do we have a distant disease? Would you want to do a targeted biopsy for this, get an ERPR on the distant site as well? If it is concurrent, and if you are going to have, say, for example, a liver lesion, you would definitely ask for a sono-guided FNA for this lesion. Why? Because you're also going to consider them for RFA or targeted treatment for the liver lesion. But doing an ERPR on them, no, we are not doing it, because if the biology is looking, I mean, if the morphology is looking similar, we would assume this to be the same as the primary, and it is not going to impact on treatment differences. And that also I'll explain. If the primary has turned out to be a HER2 positive, and you're distant when you're aspirating, you get some tissue in the FNAC, which on those few cells, you're not able to show HER2 expression. Would you then say this is a HER2 negative distant metastasis and I would not give targeted therapy? No. And the other way, the counter thing is that if you're getting ER positive on the primary and you're not getting it on the distant side because it's an FNAC, you would not change your treatment. So it is still going to be based on your uh, primary tumor itself and what it is expressing. So doing an FNAC in every one of them, I don't think so. In a bone-only disease, I'm not going to go and do a targeted biopsies or bone biopsies to get confirmation of diagnosis. I think a PET uptake is good enough for us to say that this is a disease which is cancer versus not. So I think that is completely closed there. Geeta, you have any comment on this?
So, if it is a liver-only metastasis, I would go a step further and possibly, do a biopsy and place a clip there. Because, sometimes if it were to disappear, then, you to do an RFA may be a little tough, but yeah. And, if it is a lung thing, obviously you cannot, and like you said, if it's a 6 millimeter thing in the lung, what do you do? So, if the PET says and there is, definite indication that it is metastatic, you cannot access it. Go ahead and treat her like you would a locally advanced disease. You would do if a PET has been done prior to treatment, you would repeat a PET at the time of completion of treatment, and you will get surrogate evidence that this was. If it disappears, it possibly was. But sometimes this is a tough ask, especially the lung bits can be very, very difficult to assess because you can have concurrent infections, infective nodules. There is no way to tell. But if it is a solitary thing, subpleural in location, looks very, very distinctly metastatic but unamenable to a sampling, then you should just wait for the surrogate evidence and treat her accordingly.
So in other words, I would say that if there is a lesion that can be biopsied, like surface lesion in a lung, you have a large mediastinal node which can you do a EBUS, or if you can actually do a CT guided biopsy for some nodal mass, I would still get it to confirm the diagnosis, because then I'm labeling them, especially if it is limited disease and you are intending to treat them as oligometastatic or not. But then there is another question on mediastinal nodes. How do you treat them? Do you treat them as one node, two node, three nodes, as number of sites? Mediastinum is treated as a visceral disease. It is not a nodal disease alone. Mediastinum is a diffuse involvement because there is no sequential lymphatics that you see in breast cancer. It is different when you're treating them with lung, because that is a sequential. Then there are levels that you talk about. Esophagus, there are levels that you talk about. But in breast cancer, with involvement of mediastinum, is always treated as a visceral disease. Now, would you treat them or not? I think that's a MDT decision that you have to take. If it's a very superficial, say a prevascular single node that is there and that looks like deeper to the internal mammary, you might still say benefit or doubt, I will do an extended RT and cover this later. But generally, a mediastinal node disease is not treated as a oligometastatic breast cancer. It is to be treated as distant disease only, and it is multiple nodes involvement. You may see 4, but there will be at least 7. That kind of a disease, because there will be multiple tiny ones which you can't really evaluate even on PET. So I think a mediastinal disease has to be really individualized, and you can't put them into one basket and say it is to be treated as an oligometastatic disease if that is the only site. Now again, size here does not matter. If there is a large node, that's what you will see obviously in PET, but the sub-centimeter nodes will be very easily missed. So if there is an 8 mm, 7 mm, you don't even know whether this is really the uptake is infection or it is disease. You would not want to treat them wrongly. There is enough proper randomized evidence to say you harm when you do surgery in an M1 disease. So they treat them as visceral disease and not as locoregional.
And the thing is, again, mediastinal nodes need to be taken with a pinch of salt. You need to prove again, because a lot of times there'll be nothing in the axilla, nothing in the supraclav, and you'll be having these mediastinal nodes. And a lot of times you will get granulomatous disease also in these lymph nodes. All the more reason to prove whether it is or it is not part of the disease.
Yeah. So there, I think a tissue diagnosis is mandatory, and taking a very wise decision not to do or do something. So it's not like that you will say there are only two nodes seen and I'm going to treat it, because it all depends on where this is situated. Does it go and involve those two nodes alone as a sequential lymphatic spread? There is no evidence to that. It is to be treated as visceral disease and not as a lymphatic spread alone. Okay, then we have another, removing primary causes progression of metastatic site mechanism, and does it hold true, Geeta?
So I just showed in my slides. I'm sorry, but you were not able to see a lot of my slides. So one of the hypotheses is that the primary, intact primary, is known to, give rise to immunosuppression. The moment you remove the primary, that immunosuppression goes, and there is this theory that it does. And I know that Dr. Badwe really feels very strongly about this. That he was talking to me the other day, and he's saying, you remove the primary, and there is a tendency to progress at the metastatic sites. So I think we need more evidence on this also. We don't have it, but it is one of the hypotheses that yes, removing the primary can actually cause a flare at the metastatic sites.
So I'll give it a name. It's called the autonomy theory. That means as far as the primary is present and there is distant metastasis, there is some degree of control exhibited by the primary on the distant site. If you remove the primary, you're giving autonomy to the distant site. And then there is a flare in disease in the distant site, which is what the M1 trial really showed. That even though you had a fantastic local control of 84%, there was a distant increase of 4% of detriment of survival in the locoregional therapy arm. So there was a detriment of survival in locoregional therapy arm in the M1 trial. So that has to be kept in mind. So you may achieve a fantastic local control. For you and for the patient, it appears like, oh, you've removed the disease and you can do your muscle flexing. But what happens in the distant site is something time tells, and there is a detriment and outcome in the patient with locoregional therapy in M1 trial. All right, so they say that there is what would be the treatment approach into practice for de novo oligomet disease, which had not responded to systemic therapy, that means stable disease at both primary and distant site. What is the approach?
So this obviously tells that that she's a non-responder. If somebody is not responding, that should ring alarm bells in your head. And I would not think of surgery at that point. I will only think
You've
of
already
changing
answered that.
systemic treatment and not do anything.
Okay, so somebody, Caleb, is asking, in induced oligometastatic disease, when would you decide the intent of treatment, a priori or after response to chemo? Obviously, after response to chemo. So you are looking at, well, two things. So if your after response to chemo shows no response and you have progressive disease, that's where you're only going to palliate. So you may then address the local for fungation or bleeding. But if there is a response on induced oligometastasis, that means polymetastatic responded and there is an induced oligometastatic disease, you would not do a surgery because this is obviously a polymetastatic responding to treatment. You would observe, you would not do a surgery because this is the same subset that was included in the randomized trial in Tata Memorial, which clearly showed there was detriment, and I've just explained the results to you. So I guess that answers it. Will the effect of systemic therapy decide the intent of treatment? No, hold on.
Yeah,
I
will the
think I
effect
missed
of
that.
systemic therapy decide the fate of genuine OMBC, or we will offer surgery to all? So I have a very interesting case to, relate to you, which is a young girl. She's about 38. She's ERPR positive, HER2 negative, solitary metastasis, sacral region on PET, has completed chemotherapy. So we are thinking oligometastasis. But now when we got a repeat PET CT done, there is reduction in the size of the primary. There is a decrease in the SUV of the sacral metastasis, but there are a whole lot of healed lesions in the axial skeleton. So she's got, around 5 or 6 vertebra which show healed lesions, which were not picked up in the original PET. So what do you do with such a patient? So, basically you're looking at response. So technically the response is there in the sacral met also, but there are these healed lesions. So does your definition change now of oligometastatic disease?
So I would look at this as, a bone only metastasis, but multiple bone metastases which have now healed. So she becomes polymetastatic and she's responding to systemic therapy. Why would I disturb her homeostasis? Why would I do anything? She's responding on the primary, she's responded on the bone, she's showing a very good response to treatment, she's hormone receptor positive. Just because she is bone only metastasis, I'm not going to intervene, because yes, even in the polymetastatic disease, if it is bone, multiple bone and multiple axial bone, it still behaves not as a solitary bone. It behaves like visceral disease. So you have to take it into consideration that if it is multiple metastasis responding to treatment, don't disturb her system. I mean, if she starts progressing again, that's a palliative surgery you want to do, that is a different thing. But if she's responding and she's fine, leave her alone. Why would you want to disturb that mechanism now?
It is just that the conversation is a little skewed because initially you said oligometastatic, and basis the PET CT that you're seeing now, you think those healed lesions which did not show up in
That
the
did
first
not.
PET.
So I'll come back to it. So the TMH trial looked at patients who had responded to systemic therapy. Some of them were endocrine only. All of them were not chemo. So there were a subset of patients, ERPS strong positive, who were given endocrine therapy alone and then randomized. So if you look at those who had response, in them you had again classified them into whatever, less than 3 to more than 3. Now you can see that there is no benefit in either groups. So why would you address a patient who was polymetastatic to begin with? No, we have excluded oligometastatic disease, true
Yeah.
oligometastatic, genuine oligometastatic is out. Now she is a post-treatment oligometastatic because everything is healed, one is remaining, and tumor has responded. So
No, but those were
post-treatment
not
one is
seen. That is
different.
what I'm saying. I'm saying she
Seen
was
or
only
not?
solitary bone. But this healing thing has, retrospectively shown us that they were possibly involved.
So wait and watch for a while. Let us
Yeah.
see if these lesions how they behave. I
Right.
think she did
Also,
not
Geeta and
answer
Vani,
it.
there is one more question which a student has asked. So, should we integrate a liquid biopsy in these patients? Like, what Geeta told, what looked to be a solitary mats, now what Vani agrees that it's a polymat, so it's a different ball game, totally now. So is there any way a liquid biopsy ctDNA is
CTCs.
integrated in this to know the volume, burden, response? A student has asked this
How
question.
How much has this proven itself in early breast cancer also? Tell me. Even in metastatic breast cancer, it is not a standard of care to monitor patients with ctDNAs. And what would you expect? This is a patient with systemic disease anyway. And that burden of disease cannot be measured with ctDNA alone. Because these are sites which have some responded, some not. How would you take the ctDNA as an indicator for deciding whether you will do a primary treatment or not? It is
That's
still a
right. That's
systemic
right.
disease.
So
I
the
would
answer to the
reserve,
student's thing
yeah,
is, even though
ctDNA.
it is exciting as a research, as of
Yeah.
now, it is
Yeah, I would
not
reserve
a high
CTCs
level
and
evidence.
ctDNA for systemic treatment, not for deciding primary treatment. And that too for those patients in whom the intent was cure to start off with. But you do surgery and you find that, she has got a lot of lymph nodes, not responded very well to systemic treatment. These are the patients you may want to monitor, but be very, very certain as to what you're trying to tell the patient. Because, you could have CTCs, but, there may not be any radiological evidence of disease for about 9 to 12 months post picking up these CTCs. I think it has to be used with caution.
I think it's more an
Good.
industry driven one, and secondly uh, research subject. You can do anything there, but you can't be doing these serial tests on patients and then labeling them as still carrying the burden of disease. Do you imagine the subset of patients who are coming for follow-up who are absolutely asymptomatic? It has already been proven that doing intensive investigations for a patient on a regular follow-up to look for disease which is evident, clinically evident disease or radiologically evident disease, itself has not shown to be have any benefit. Now you're going further down and you're saying I'm going to look at only cells circulating in there and then call the patient as still M1 versus not. I don't see why we would want to
Absolutely.
go into more
Absolutely.
sensitive
So,
a test.
students, yeah, it's important to know there are some diseases where there is no role of active surveillance to pick up the disease, like, in ovarian cancer, doing CA125 and intervening biochemical failure versus clinical symptomatic failure, breast cancer, just doing intensive workup and intervening in a subclinical asymptomatic, or when they become manifest, there's no difference in OS, unnecessary quality of life will come down. So, we don't do that. There are some disease where it is. So most of the ctDNA work and studies are coming only in colorectal, and that too it is not proved. I agree. So all good things has to end. I always say that the purpose of the teacher is to stimulate the brain. We can't spoon feed them. Now that you're given a direction there to walk in. Before we part, only one line. does a triple negative versus HR positive HER2 negative influence you offering primary treatment in janine oligometastasis, or you think it's okay? Because I know, this definition of oligomats itself is like, whimsy. But does the biology of the disease in form of TNBC versus ER positive, like say luminal A or B, influence you in deciding primary surgery if a small subset of patient you want to offer a primary treatment? First to Vani and then to Geeta.
So I think that in a genuine oligometastatic breast cancer, biology does have an impact and the site also has an impact. But one has to do a value judgment for that patient in the sense that if she's able to afford a anti-HER2 therapy and she's got a solitary liver met and she's HER2 positive, I may still go ahead and give her systemic therapy, do the coiling of the lesion, do the systemic therapy, followed by surgery to both, addressing both, either RFA or surgery to the liver met and to primary. But in a patient who is, say, a HER2 positive but is not affording an anti-HER2 therapy, doing something to the distant site is not going to help because she is going to come back with progression very soon.
Triple
Similarly,
negative versus luminal A. Does
no,
it influence you offering?
it does
No,
not.
I
It
will
does
say
not.
we will leave the polymetastasis. We
I'm
will
not
say
even talking of
oligometastatic
polymetastasis.
disease,
I'm
triple
not talking
negative
of,
versus luminal A.
correct. I'm not looking at polymetastatic. I'm talking of oligometastatic. In oligometastatic, again, availability of treatment decides. So a triple negative also with a solitary met, I will counsel the patient that you still have a higher risk for disease coming back. But since you have a solitary lesion, I will address it. But it does not, so biology does not impact your decision for a genuine one. You would still offer as long as they're taking their full systemic therapy. So you have to ensure that they receive systemic therapy first and then offer treatment to the primary and distant.
Okay, Geeta, to you, because most of the studies show, bone only oligomats, HR positive, are the one who derive the benefit, if any they are. So it's in your back of mind that nobody has done only a triple negative oligomats separate and look. I know that itself is such a small group, nobody will do it. But would you offer a primary surgery in a metastatic disease in a janine oligomats if they are triple negative?
So in triple negative, I look at it very differently. See, triple negative, it has gone out means it is aggressive. We know triple negative to be an aggressive disease. Like Dr. Vani said, in a luminal A HER2 positive, I would possibly consider surgery at the end of your systemic treatment. But in triple negative, I'll wait it out longer. I will wait out for the disease biology to show up. So if she were to, I could wait for as long as a year to 2 years, possibly, even for a triple negative. Definitely a year. If within a year there is no progression because you've stopped treatment, or maybe the patient is on capecitabine or whatever, but I would not jump into surgery earlier in a triple negative as compared to the other ones. I will definitely wait it out for triple negative.
Thank you. Thank you very much, both Geeta, Vani. Students, it's a dialogue between two giants. Actually, what I